I've just started the record.
Okay.
Hi everyone. We are on day 4 at Rapid, and today we've got quite a long topic and a long presentation. We've got gastro. It's actually really interesting. Think about it. So we've got the wonderful, who's going to be doing the teaching. Whenever you're ready.
Yep, thank you. Okay. Hi everyone, I'm Suzi. I'm an F1 in Chichester at the moment. I'm currently working on the emergency floor, but I have just finished my gastro job. So I thought I would try and teach you a few of the things that I've learned in 4 months on gastro as an F1.
That's perfect. We've actually got people joining in today. Hello, hi. We've just started. Welcome to the and
So obviously there's a lot in gastro. There's lots of different parts of it. There's lots of different diseases. It's easiest split into the different parts of the GI tract. So kind of upper GI tract. There's a few things associated with that. So from the mouth to the stomach, and then hepatobiliary, there's a lot in that. So like the liver, the gallbladder, all of that kind of stuff. So there's quite a few conditions in there that we can talk about. And then the lower GI tract, so that's more of like the IBDs, celiac disease, which affects a lot different areas, and colon cancer is also quite a big topic and quite like a high yield topic in finals, I think. So we'll start with the upper GI tract. So the first condition, peptic ulcer disease. So this is basically when you get ulcers in the stomach or the duodenum. There's lots of things that can predispose you to these. So things such as H. pylori infection, which I'm sure you've heard of before, smoking, stress. Some people say kind of like a diet high in red meats, lots of rich foods, and certain drugs. So I think the one we always think about is NSAID. So a patient coming in who has been taking 4 paracetamol every day for the last few months. That's obviously a red flag. Often it's people who've got like joint pain or back pain and they don't know that NSAIDs can cause these kinds of things. So always something to look out for, especially in OSCEs. Steroids and bisphosphonates are another one that can predispose you to peptic ulcer disease. So the broad management is you need to find out if the patient has H. pylori, because if they do, then you want to treat that. You want to give them a PPI for 4 to 8 weeks to reduce the stomach acid, give the ulcer time to heal, and obviously look at the medications they're on, because if it's been caused by medication, if you don't stop that, then it's just going to recur. And like I said before, smoking, stress, certain foods, trying to change the lifestyle to reduce the risk of it recurring. And then it's different for gastric and duodenal ulcers. So for gastric ulcers, you want to do an OGD. So that's a camera test down the throat into the stomach to have a look. And you want to do a H. pylori test 6 to 8 weeks after to make sure that the ulcers are healing. And you might consider a long-term PPI. There's kind of conflicting opinions about that, but sometimes you get put on a long-term PPI, just a low dose, like 20 milligrams. And then duodenal ulcers, again, you do the H. pylori test 6 to 8 weeks later, and you probably go on a PPI long term as well. So the complications, obviously bleeding. So one of the most common kind of emergency presentations in gastro is an upper GI bleed, and very often that's from a peptic ulcer. Perforation, obstruction, and if they continue to persist and they don't heal, they can transform to become malignant as well. So it's important that we treat them when we find them. And then GORD is a very, very common thing. People present with it all the time, very commonly to GP. Not so much in secondary care, but yeah, it's something that it's definitely important to be aware of. And the main investigation is a lot of the time it's done on just on symptoms. They don't actually do any invasive investigations, but endoscopy. So again, camera test down the throat, and it's important to note you have to stop the PPI 2 weeks before to give a true representation of what's going on. And management can be just kind of conservative things like raising the head, sitting up after eating, not going to bed too quickly after eating rich food. Don't eat rich food in the evenings. And then PPI, also for kind of 1 to 2 months. And just over the counter antacids like Gaviscon can be really helpful. And then Barrett's esophagus. So this is a condition when you've had GORD, not necessarily for a long time, but the longer you have it, the more likely Barrett's is. So the acid is coming up into the esophagus and it causes metaplasia of the cells. So it changes the cells from squamous to columnar cells. It's not a malignant condition itself, but it's kind of like sometimes it's sort of as like pre-malignant, and it does put you in increased risk of malignant transformation into an esophageal cancer. So again, for most things in gastro, I have learned on my job that the investigation is an endoscopy. So they just have a look down and see what's going on, and then they can decide what to do. And also potentially regularly biopsying just to check that there's been no malignant transformation. And the patients won't really necessarily have specific symptoms for Barrett's esophagus. It will just be that they've probably had GORD for a long time. So you want to check up on those kinds of things. And again, the management is just lifestyle changes, not smoking, decreasing stress, less alcohol, etc. Treating H. pylori if they have it, and then some more kind of invasive things. You can take a bit out, mucosal resection, you can ablate it doing an OGD, or you can take the whole esophagus out, which is quite extreme. I don't think that happens very often, but that's a potential management option. And then hiatus hernias. So hernias, obviously something moving into an area that it shouldn't be. So the stomach moves up into the chest, kind of through the diaphragm. There's 2 different types, the sliding and the rolling. And it's kind of mostly, it's managed by the surgeons, really. You can investigate, you can do a barium swallow and look at where it kind of lights up. Again, you can do an OGD. Lots of patients who are having OGDs for other things, they incidentally find a big hiatus hernia, and then they can refer to the surgeons if it needs repairing. Again, present with GORD symptoms because you've got stomach in your chest, so everything's got a lot of pressure and things, the acid's coming up. And the main management is fundoplication, which is, I'm not 100% exactly how it works, but I think they kind of put some staples in and keep it down in the stomach where it should be.
That's essentially what it is. They push it back down.
Yeah. And then gastric cancer. So few risk factors: men, older age, H. pylori infection. So I guess the theme is that it's really important to treat H. pylori infection because it can cause a lot of different things if it goes untreated. The classic lifestyle things like smoking, not eating lots of fruit and vegetables. Pernicious anemia can also predispose you to gastric cancer. It usually presents quite vaguely. It has the kind of classic like weight loss, sometimes night sweats, nausea and vomiting, abdominal pain. But obviously there's so many things that can present that way. So sometimes it's important to think about the kind of constitutional symptoms and then which investigations you might do. Dysphagia is also a big one. So whenever you see a patient with dysphagia, it's always a red flag. You should always think what is going on in this patient for them to have dysphagia. If it's malignant, it's often esophageal cancer, but if it's from the kind of top of the stomach, that can also cause dysphagia as well. And then the two kind of classic things, I'm not sure how common these are in practice, but definitely for exams and things like that, the left supraclavicular node and the periumbilical nodule, they're like kind of like cardinal features of gastric cancer, but they can occur in other cancers as well. But that's the main one. And then again, investigation, of course, endoscopy, biopsy, and then you'd probably want to do a staging CT and things like that. And it would be referred to oncology. So management, you basically want to take out the bit that's got the cancer. So you might take part of it out, you might take the whole stomach out, and also chemotherapy and also maybe radiotherapy if that was suitable, depending on where it was and the response to the treatment. Okay, so that's kind of upper GI, and then moving on to hepatobiliary, which in my experience, I would say is probably what makes up most of what you see on a gastro ward. Most of the stuff is kind of liver, gallstones, that kind of thing. And again, I think it's probably one of the most important parts for finals. So yeah. Alcoholic liver disease is a big one. You see it a lot when you work in gastro. Lots of kind of symptoms that present well in OSCEs, things that you probably should be aware of for finals. So jaundice is obviously the big one, the yellowing of the skin because the bilirubin. You get gynecomastia in men, the spider nevi on the chest and the abdomen, ascites, so all the buildup of fluid. So big rounded bellies is a big kind of cardinal symptom of alcoholic liver disease. Palmar erythema, so the darkening of the palms, the caput medusae on the stomach. Finger clubbing, that can also be a sign of lots of different things. Just general edema. And actually, a lot of patients, you have the kind of textbook, like this picture here, the textbook patient, and actually, a lot of patients look like that in real life. They've the symptoms of liver cirrhosis, so that's kind of like end stage disease when the liver's kind of shrunken and just not doing its job. Is when you don't always get ascites, but a big abdomen, swelling, weight loss. The patient just feels really rubbish because obviously the liver is responsible for helping with clotting. So you get lots of bleeding, bruising, itching, and tremor as well is a big one. And then the physical findings, I've just kind of spoken through those. So then non-alcoholic fatty liver disease, that is basically you can get a similar phenotype to the patients who do have alcoholic liver disease, but it's obviously not caused by alcohol. So it's often caused by high fat diet. But I think they're trying to recategorize it a bit now. It's because this non-alcoholic is like NAFLD, but they're changing it to like MAFLD, like metabolic associated fatty liver disease. And like I say, it's mostly due to excess fat in the diet, but actually sometimes patients come in and it's drug induced, and their liver's basically failing for a reason that isn't alcohol. So the risk factors, like I say, central obesity, diabetes, high lipids, hypertension, all those kind of that metabolic syndrome that you think of. Sometimes patients present asymptomatically, and because they're overweight, they might get screening for their liver and then they find that it's failing. The liver can be big as well. So investigations, you always want to do anything to do with the liver. You want to do like a full non-invasive liver screen. So you do the kind of LFTs and all the hepatitis bloods and all of those kind of things to see what's causing this liver dysfunction. And in non-alcoholic fatty liver disease, the ALT is usually more raised than the AST. And then ultrasound scan, again, most of the time, if there's something going on in the liver, the first line test will be an ultrasound. And then if that's abnormal, you then progress further on to more, sometimes more invasive things. and you always would refer to the hepatologist, and they might do like a FibroScan to see if there's any, like how much fibrosis there is. They might even biopsy if they're worried about transformation to a liver cancer, for example. And management is treat the symptoms, lifestyle changes, weight loss, those kinds of things. And then if it progresses, they'll then treat what's going on as it progresses. And then jaundice, that's kind of one of the cardinal symptoms of liver failure. So I mean, I won't go too much into the like science of it, but the breakdown of hemoglobin is bilirubin, and the liver processes the bilirubin. So if the liver's not working, the bilirubin is going to build up, and that's what causes the kind of yellowing of the skin in the classic presentation. And Gilbert syndrome is one of the conditions where there's a defect in the conjugation of the bilirubin, so it builds up, and that's kind of a more of a genetic thing. It's not like the alcoholic or the non-alcoholic fatty liver disease. Yeah.
Just to add on, when you think about jaundice and post, that's how you decide what investigations. So the reason why I've put this looking at what's actually pathology, then you can think about it. So the investigation, that's what the treatment, or they are drug induced hepatitis, or very different, a carcinoma on the head of the pancreas, even though both of them present with jaundice. So it's about understanding what's causing it and making a plan.
Yeah, so hepatitis is kind of literally inflammation of the liver. And there's obviously a couple of different types. They're spread differently, they're caused by different things. And for finals, it's definitely quite good to learn these. It's a bit kind of monotonous, but learning the things, how it's transmitted, what tests you want to do, and how each is managed is quite important. And you do this in practice. We often get people coming in with deranged LFTs. We don't know why. And we do, like I said before, the non-invasive liver screen. And they come back, for example, with Hep A. They've eaten something funny and they've got a hepatitis that just gets better on its own. So just starting with Hep A, it's fecal oral, self-limiting, so you don't actually need to do anything. It usually just gets better on its own. You want to do the IgM and the IgG antibodies to look for current infection and to look for past infection. And then if they're positive, you do the Hep A RNA, the general LFTs, and then ultrasound liver might be necessary as well. And again, supportive management, and monitor the LFTs to make sure that they resolve. So if we have a patient who comes in, we send them home, we get the GP to redo the LFTs in 4 to 6 weeks to make sure that they're getting better. And then hepatitis B, so that is a bit different. So it's spread vertical transmission, usually sexual contact, IVDU, tattoos, needles, that kind of transmission. So the first thing you see in the blood is the hepatitis B surface antigen. I find all the different antibodies and antigens very confusing, and you sometimes just have to sit and go through them in your head and find yourself a way that you're going to remember them. So the IgM is the first antibody to rise. The IgG will stay. If you've had it, you'll always have the IgG. And I always remember the core antibody as like caught. So if the core antibody is positive, you have the hepatitis because you've caught it. You haven't been immunized against it. And there's a few ways you can treat it. Mostly it's supportive, liver biopsy to see if there's any kind of extensive changes, and also just educating about vaccinations, and you can give the people the vaccination afterwards to try and help clear it.
hepatitis B, the markers are very, very important, very, very confusing. So for all of my students, they know. So whenever there's something underlined, that's a link to a video. So this slide, I'll put it in the description of this YouTube video. But there is a DirtyUSMLE video where he talks about all of the different biomarkers when they present, how to interpret it. And I watched that in med school. And I always rewatch it because I forget. So that's a really good resource rather than just memorizing it. He explains it really. And just to mention that hepatitis is a notifiable disease. So for Hep A, Hep B, if you're coming across patients, notify the health authority. Uh, because there is, for hepatitis A especially, there could be like an epidemic, like a lot of people could get sick, whatever the source of infection was. So yeah, that's
And then Hep C, similar transmission routes to Hep B. So again, like vertical, sexual, needles, tattoos, blood transfusions. And when you are investigating for Hep C, you look at the antibodies and also the RNA of the virus. If it's positive, then you repeat it, and if it's negative, you still want to repeat it 3 to 6 months later just to check that it's still negative. And similar management to Hep B, but you can give some antivirals for Hep C. I won't try and pronounce those antivirals, but just know you can give them. Some people may need a liver transplant. Obviously, there's quite strict criteria for liver transplants, but that is a potential treatment for Hep C if it's necessary.
also apologies for all the typos. I'm just realizing there's quite a few. I'm post nights, so please excuse all of the typos.
We know what it says. So gallstones is a very common presentation to gastro. Basically stones building up in the gallbladder. They can be made of lots of different things, such as cholesterol. They can be pigmented stones. They can be mixed. There's lots of different things that can cause gallstones. So people classically present with the kind of biliary colic pain, nausea, vomiting, infective symptoms. So they just feel generally really unwell. They've got abdominal pain, they've got a fever. So cholecystitis is the inflammation of the gallbladder, and that classically presents with the pain, fever, and right upper quadrant tenderness. And then cholangitis is the inflammation of the bile duct, and that presents with jaundice, fever, and right upper quadrant pain. Acute pancreatitis, that's another one that can present epigastric pain, vomiting, those kinds of, there's lots of different things that present in that way when someone comes in. So you have to kind of think, where is it coming from? Is it coming from the gallbladder? Is it coming from the bile duct? Is it coming from the pancreas? Risk factors for these things, there's that classic acronym, which is not very PC, but it's a way to remember it. The kind of female, fat, 40, fertile woman is the kind of classic patient. And in practice, a lot of the patients maybe fit that stereotype, but a lot of them don't. So don't be kind of swayed if the person doesn't fit that exact kind of stereotype. It kind of occurs between the age of 40 and 70. Lots of people who have high fat, low fiber, not lots of fruit and veg-esque diets. People who have lost a lot of weight. Sometimes people who've had kind of bariatric surgery can be more predisposed to gallstones. Genetics can play in, Crohn's disease, diabetes, and certain medications can make it more common. So you first want to do an ultrasound to have a look if there's any. You can often see like a dilated bile duct or inflammation around the gallbladder. Sometimes you see they say that you can see kind of sludge in there, which is causing some problems. You want to look at the LFTs as well to see if they're deranged. And then if you're concerned for a stone, you would normally do an MRCP, so that's an MRI scan, to have a look in more detail. And then an ERCP is where they go down the throat and they kind of go down with a little camera and scoop out the stones. They might put a stent in as well if they need to. It's a kind of invasive procedure to remove the gallstones. So the management, if it's asymptomatic, sometimes it just resolves on its own. People pass the stones. Sometimes if they're in the gallbladder, they're not causing any problems, that's fine. The stones can be passed kind of spontaneously. If there's a stone in the CBD, you would normally refer to the surgeons. And again, if they're symptomatic, sometimes they will take them out with an ERCP, but sometimes you need a cholecystectomy, like to take the gallbladder out. And it's down to the surgeons whether they do it kind of hot or cold. So hot is when it's inflamed, which they do less so these days. But there's certain indications for that. And then it's more likely they'll do a cold, like chole. So wait for the infection to resolve and then they take the gallbladder out. And then acute pancreatitis, another common presentation. Lots of causes for this. There's that mnemonic I get smashed, which is actually very useful. It does actually cover the majority of the things. Obviously, scorpion stings are not very common, but they can happen. I think the two most common ones are gallstones and ethanol. So alcohol and gallstones will definitely be in practice the things you see causing acute pancreatitis most commonly. It can be caused by, like I say, if it's gallstones, the different types of stones. Classically presents with epigastric pain, which radiates around to the back. When you lean forward, it kind of eases it. And the patient's just generally pretty unwell. They're in a lot of pain. They might be vomiting, have a fever, things like that. Then there's the two kind of classic signs, which I don't think I never saw in real life. I don't think you see them that commonly. The Cullen sign, so it's like above the belly button, and the Grey Turner sign is like the bruising at the flanks. So you want to do bloods, obviously. Amylase is one of the most important if that's usually raised in pancreatitis. Lipase, and then you do the Glasgow score to I can't remember what that's actually for.
You assess the severity and then it helps you decide
Yeah.
the prognosis and things.
Yeah. Again, haven't seen it used loads in practice, but it's definitely one for your exams to learn. So management is generally just trying to treat the underlying cause. Obviously, if it's gallstones, treat the gallstones, alcohol-induced, alcohol cessation, counselling, all of that kind of stuff. Usually patients will need admission, rehydrate them, give them analgesia, and just monitor to make sure things don't progress. So pancreatic cancer is another one. Presents classically with painless jaundice, the kind of pale stools, dark urine, obstructive jaundice, because the cancer will be putting pressure on the kind of biliary system, causing obstruction. You can get an abdominal mass. So the law, Courvoisier's law, is that if you've got painless obstructive jaundice and a palpable gallbladder, it's unlikely to be due to gallstones. And if there's an epigastric mass, it's probably going to be more likely from a pancreatic cancer. You've got the B symptoms, so the weight loss, fever, night sweats, and some endo and exocrine dysfunction. So pancreatic cancer is often diagnosed very late because the symptoms can be quite non-specific, and often once the patient becomes jaundice, it's actually progressed quite far. Generally, the management will be surgical. If it's kind of a head of pancreas mass, they might be able to resect it. General analgesia because it can be very painful, supporting nutrition because of the endo and exocrine insufficiency, and sadly a lot of patients will be referred to palliative care because it's diagnosed quite late and the prognosis is quite poor.
And a lot of the times it's hard to figure out what the underlying cause is because they present with, say, endocrine and exocrine dysfunction. So they might present with like diabetes, gastric issues where they're struggling to like digest things, and it's all a bit vague. So just like a clinical tip is when things don't really make sense, when they don't really fit, think of something more sinister that could be going on, um, because there's probably something else that you can't really see.
And then primary sclerosing cholangitis, bit of a mouthful. So it's like PSC and PBC, are the two kind of chronic inflammation in the liver. We don't really know exactly what causes them. They are associated with specific things. So PSC is commonly associated with ulcerative colitis. So it's kind of middle-aged men who have ulcerative colitis, they're much more likely to get PSC. They will have a raised ALP, and doing an MRCP is the kind of gold standard investigation because it helps you look at the kind of fibrosis of the liver. So you'll want to assess. Sometimes people haven't actually yet been diagnosed with the IBD, but often they are patients with IBD who now present with these symptoms. They might be itchy, just general fatigue, fever, night sweats can obviously also be so people associate that with malignancy. So it's important to try and think about what's the background, what's most likely, and right upper quadrant pain because of hepatomegaly. So, unfortunately, the only kind of definitive management for this is a liver transplant. Patients who are quite fit will normally be the best candidates for this. Older, more frail patients wouldn't be a candidate for it, but usually it presents in the younger people. So that is a possibility. You can do ERCP, so go down with the camera and put a stent in if there's any stricturing to kind of open things up. UDC acid can help, and cholestyramine is another bile acid sequestrant. I can never say that word. And it also helps quite a lot with the itching as well, those two drugs.
Again, so PBC and PSC is something I've always struggled with because they're so close together and they're always options in like multiple choice questions. So I'll put links down to further like more in detailed videos that you can watch if you struggle like me. Um, yeah, that's all I wanted to say. So look at the description.
So yeah, PBC, very similar, kind of the etiology is quite similar. It's this one is more common in females, kind of middle-aged females. It's autoimmune, and it causes kind of it's scarring fibrosis of the liver. They present with fatigue, very similar symptoms: fatigue, itching, jaundice, right upper quadrant pain, and it's the AMA antibodies that are positive in PBC. So again, exam questions: if they give you the antibody or they ask you which antibody it is, it's AMA for PBC. Again, right upper quadrant pain, fatigue, itching, kind of the vague liver symptoms, and similar to PSC, liver transplant is definitive. And again, you can dilate and stent with ERCP or give UDC acid or cholestyramine. Hemochromatosis is another quite common thing that comes up in finals. It's a genetic autosomal recessive condition. It's a mutation in the HFE gene, which is found on chromosome 6. Sometimes they like to ask really random questions like that in finals that you obviously don't need to know in practice, but that's just something important to probably learn. Very common in Northern Europe, and you get kind of iron deposits in lots of different organs, which can cause organ dysfunction. So commonly presents with very severe fatigue, impotence, joint pain. The classic patient is the kind of patient with very pigmented skin, so bronze, darkened skin. You can get cirrhosis because of the deposits in the liver, and diabetes because of deposits in the pancreas. So there's when you're looking at hemochromatosis, you want to do full iron study. So the ferritin, the iron, the transferrin saturation, all those kinds of things. And there'll be, when you do iron studies, there's a certain pattern for certain conditions, and I can never remember them off the top of my head, but there's lots of like nice pictures if you look on Google of what's raised and what's low in different conditions in relation to iron studies. And I found
cover that in hematology, in the anemia related bit, because the total iron binding capacity, the serum ferritin, and all of that is really relevant.
yeah.
So we'll do all of that in that session.
And actually what you do in practice, if you think someone's got hemochromatosis, and often the iron studies don't exactly correlate with what your suspicion is, you do the genetic testing. So you send off the HFE gene, and if that comes back positive and your iron studies are kind of deranged, that points towards a diagnosis of hemochromatosis. The mainstay of management is venesection, which patients need to come in for kind of semi-regularly, depending on how severe it is for them. And there's a range of complications, again, because the iron deposits in all different organs. Some common ones, though, are cardiomyopathy, hypothyroidism, hypogonadism, and HCC, which is the liver malignancy. Okay, so liver is done. Moving on to the lower GI tract. IBS, so very common thing for lots of people. It'd be very common in kind of GP settings, so in OSCEs or the kind of GP section of the exam. IBS is very relevant. So there's no kind of, it's one of those conditions where there's no kind of definitive test or way to diagnose it. It's diagnosed on basis of exclusion. Basically, you exclude other things that it might be, and then if it's none of those things, it's most likely IBS. So the definition of IBS is it needs to be going on for at least 6 months, with abdo pain and or bloating and or a change in bowel habit. So ABC is a good way to remember that. The red flags are if they're over 60, it's very uncommon for it to present for the first time in people over the age of 60. If there's any kind of rectal bleeding, you're thinking, is there something else going on? Is this a lower GI bleed? Is this a malignancy? Any unexplained or unintentional weight loss? Again, that's going to kind of point you more in the direction of celiac or an IBD. And any family history of cancer, especially bowel or ovarian. Bowel cancer obviously can present with rectal bleeding. The unexplained weight loss. Ovarian cancer can often present with kind of abdominal bloating and things like that, and abdominal pain. So the main things that you would do are full blood count, ESR, CRP, and you want to do the celiac disease screen, so the TTG antibodies, to exclude celiac as a potential cause of these symptoms. The main thing for management is kind of dietary advice, avoid foods that, trigger it. There are some medications you can give. I think they've got kind of different successes. You can give kind of antispasmodics. You can have like peppermint oil, buscopan, that kind of thing. If it's more constipation, there's kind of two types of constipation predominant and diarrhea predominant. So obviously, if it's constipation predominant, you might want to give a laxative. And if it's diarrhea, you might want to give loperamide, but you don't really want to kind of rely on that long term. You can give tricyclics second line. CBT is another thing that has been found to be quite useful. And you wouldn't refer to gastro for IBS, but if the symptoms persisted despite trying lots of different things, or you weren't sure if you thought this might be celiac, this might be an IBD, that's when you would refer to gastro for further advice. And then celiac disease is autoimmune condition against gluten, causes damage to the small intestine and then malabsorption. So it's really important that it's diagnosed in a timely way. So common presenting symptoms are abdominal pain, loose stool, feeling very tired. In children, they don't grow as well because they're kind of malnourished because they're not absorbing as well through their small intestine. And a common linked presenting symptom or condition is dermatitis herpetiformis. They love that in exam questions as well, so that's a good one to remember. The main investigations are the anti-TTG, and if that is not a kind of conclusive investigation, you can also do the EMA. And it's important that when you are doing these tests on patients, they have to be eating a gluten diet before they have the blood test. If they're avoiding gluten, it's going to it might make the antibodies falsely low when actually it's because they're not eating gluten. So yeah, really important that they keep on a gluten diet. And then if those blood tests are positive, you refer to gastro and they'll do biopsies to look for the kind of villus atrophy, which is one of the main signs of celiac. And the only way to treat it is basically to have complete gluten avoidance in the diet. And then IBD, so ulcerative colitis and Crohn's disease. You see a lot of these on the gastro ward, very common presentations. There's quite a few kind of differentiating features between them. So ulcerative colitis, it only affects the kind of colon and the rectum, just the large intestine and the colon. It's continuous in as an opposition to Crohn's, where you kind of get the patchy inflammation, which can be anywhere from the mouth to the anus. And it's found usually in large sections, whereas ulcerative colitis is continuous. So Crohn's is, like I said, patchy. It's a full thickness ulcers. You often find them in the kind of lower, kind of right iliac fossa area. You can get them in the mouth, anywhere in the GI tract, basically. The main symptoms, you get weight loss, severe diarrhea with kind of bloody diarrhea. That's quite a common symptom of IBD. Fissures are commonly associated with Crohn's, abscesses, strictures, and abdominal bloating. And then ulcerative colitis, like I said before, it's the continuous inflammation. It's not patchy. It's only kind of partial thickness penetration, and it's kind of typically seen in the lower left abdomen. With ulcerative colitis, that more commonly presents with bleeding. You can get bleeding in the stool with Crohn's, but more commonly with UC. You kind of have this urgent need to go to the toilet, severe diarrhea, weight loss, and you can get polyp formation and abdominal cramping. Again, you can get that in both of them, but more common in UC. And then, yeah, lots of complications. So it's actually really important for IBDs to be picked up in a timely way and treated, because there's lots and lots of treatments for them, but the earlier you pick it up, the more likely you are able to treat with the kind of less intense treatments. So toxic megacolon is obviously something very severe that you need to look out for in patients with IBD. Abscesses, fistulas, all those kinds of things are the complications of the excess inflammation. It's associated with HLA-B27, another good exam question. They love to ask things like that. And it's not just in the GI tract, so you can get the extra GI manifestations. So kind of joint pain, the PSC, like we spoke about before with UC, erythema nodosum, pyoderma, all of those kind of rheumatological type presentations. And then again, management for both of them, I always find this really confusing, and I always get them mixed up. But for UC, if it's severe, you're looking at patients who are having more than 6 stools a day. If there's blood in the stool, if they're kind of hemodynamically unstable, they're septic, that's when you want to admit a patient for inpatient treatment for their UC. So acute management, you start with aminosalicylates and steroids. And then when that kind of dies down, you want to maintain them on the mesalazines, the sulfasalazines. You can try, sometimes they go straight to azathioprine and then they maintain an azathioprine. You can try cyclosporin. There's lots of different kind of immunosuppressants. And if they kind of fail those treatments, you might move on to biologics like infliximab. I've seen some patients come in really, really unwell from Crohn's and UC, and they failed all the kind of steroids, all the mesalazine treatments, and then they have an infliximab infusion and they're just a new person. And then you have them, I think, every couple of months or something, and it just keeps it at bay, and it works great. So it's really interesting to see when one treatment can just make such a difference for a patient who is struggling so much. And then Crohn's, again, you want to look out for similar symptoms. You want to admit them if they're kind of systemically unwell. With Crohn's, you normally start with steroids. So you give kind of IV hydrocortisone, prednisolone, and then you maintain them on things like mesalazine, azathioprine, methotrexate is used in Crohn's disease. And then again, if those things fail, then you might give biologics such as infliximab. And yeah, if there's any kind of complications like strictures, that usually need surgical intervention. Colorectal cancer, another one of the important cancers. So usually an adenocarcinoma, develops from polyps in the bowel. Different symptoms depending on where it is. If it's left-sided, you get more kind of bleeding, pain, obstruction, urge to go to the toilet. If it's right-sided, because it's obviously further away from the end of the colon, you're more likely to get anemia from bleeding or weight loss. So there's quite a few different genetic conditions associated with colorectal cancer, one of them being the familial polyp. I can't remember what FAP stands for, but you get lots and lots of polyps. Some people...
Just familial adenomatous polyps, that's the polyposis, that's the full name.
And if there's a family history of this, you'll get followed up very regularly with colonoscopies. Sometimes they do kind of prophylactic. They'll resect the entire colon because the risk of developing colorectal cancer is so high. IBD does put you at a higher risk of CRC. Again, eating a kind of rich red meat, low fiber diet is thought to increase your risk as well. So investigations. So obviously the screening program in GP is the FIT test to see if there's any blood in the stool. And then if you've got the weight loss, if you're over the age, I think of 65, changes in bowel habit. You go for a colonoscopy to basically have a look in the colon. You might also have a sigmoidoscopy if they're concerned if it's like right at the end of the colon, you might not need to look all the way through. And then more non-invasive things like a barium enema, CT colon for patients who aren't fit. Lots of patients aren't fit for a colonoscopy, so they'll do a CT colon instead. And then they'll always take a biopsy to check what cells are there and what if there's any kind of malignancy. And then staging using the Duke's criteria. They'll also do like a staging CT to see if there's any metastasis. And the mainstay of management is surgical resection plus minus a stoma and chemotherapy. So these are the different types of resection. I always found these really confusing. I find the pictures kind of show it. It's a lot more easier to visualize when you see the pictures, but obviously depending on where the malignancy is, they often don't need to do a kind of whole colectomy, so they can just take out a little part and join it up either with a stoma, which they can reverse, or sometimes it's a permanent stoma.
This is straight from past medicine, by the way, and it's a very common question. So as Susie mentioned, I found the pictures easier, and I used to draw it out, where I would draw out which part of the colon's affected, and that's the resection you do. You also need to know what's getting anastomosed. So depending on which part of the bowel is taken, what's ahead of it and what's behind it would be attached together. Or there might be like a defunctioning stoma. So this is again a very high yield slide. It's just annoying to memorize.
And then just common drugs that are used in gastro. So PPIs are a treatment for lots of different gastro conditions. But obviously there's always things you have to bear in mind. There's always side effects. PPIs, you are at increased risk of osteoporosis. And you want to monitor electrolytes as well. You want to monitor the sodium, you want to monitor magnesium. If patients are coming in very unwell on these, you might want to hold them while they're unwell. And then common side effects are just a kind of general headache, dizziness, dry mouth. You can get kind of muscle pain, itching, peripheral edema. But generally, I would say they're fairly well tolerated. A lot of patients are on a PPI, kind of a low dose PPI, and most of them tolerate them quite well. And then laxatives, again, no matter where you work, you will always come across laxatives. Most patients are on laxatives for something. Obviously, there's different types of laxative. It's good to learn which laxatives are which type, how they work, because it often dictates what you might, if a patient's presenting with certain symptoms, which laxative you might prescribe for that patient. So it's important to know kind of how they work and which ones fall into that category. And you often use them together. So, for example, you often use an osmotic or a bulk forming laxative to kind of stimulate the peristalsis, and then use a stimulant to kind of push it out, and they work quite well together. So, yeah, learning those things for finals is usually quite useful. And that's it.
It was a very short, brief overview of gastro that we've come up with. There's obviously more that you might need to memorize for exams, but this is the highest yield stuff that you'd have to know. In terms of case-based MCQ, so I'll put the form again in the description of this video, and I'll send it to your WhatsApp group, which has questions sort of similar to the format that you'd expect for your UKMLAs. And practice those, practice your question banks. If you have any questions, feel free to reach out. And I'm always happy to answer them. And yeah, that's it. Thank you, Susie, for doing the lovely talking, and for talking about your experiences in gastro as well.
Thank you.
Thank you.